I'm calling the Health and Human Services Policy Committee to order. We don't have a quorum yet. So I'm going to call Representative Considine. We're going to change the order a little bit, so he will start to go through his bill. We have this room until 5 o'clock, and it is our intention to get through all the bills. Before then, we lose the room after then, so we're going to be concise and productive. Okay. Representative Considine.
Thank you, Chair.
Sorry, one sec. The chair moves that House File 1254 be recommended for re-referral to the Committee on Ways and Means. We have the bill before the committee. Representative Considine, please welcome to the committee and please present your bill.
Okay. Thank you, Representative Jack Considine, 19B. This is better known as the Yellow Line project that Blue Earth County instituted on their own a couple years ago. It has been, in my opinion, wildly successful. They have placed a social worker in the booking area, and they have been working at diverting people with needs before they get arrested. And I'm incredibly proud of the county for having done this. It is a model that I believe can be replicated all over the state and the country. And I will, with that, I will turn it over to my testifiers, Bill Clausen, who is the Human Services Director for Blue Earth County, and his deputy, Angela Youngerberg. I'm sorry, I mispronounced that. I've known her for years. All right.
Thank you. Welcome to the committee. Please state your name for the record and proceed with your testimony.
Thank you, Madam Chair. Phil Clausen, Director of Human Services for Blue Earth County, testifying on behalf of MAXA and representing Blue Earth County. Thank you for hearing us today, members and Madam Chair. As Representative Considine said, our Yellow Line project actually began back in 2015. We had 2 years of development and a pilot phase, and then the last 2 years we've been 24/7 programming live. I'm simply going to give you our 3 primary goals and talk a little bit about our fiscal findings, and then turn it over to my colleague. Very brief comments here today. First of all, our 3 primary goals: access to service upstream. What our whole goal is, as Representative Considine said, is to divert from incarceration for chemical health, for mental health, and also for folks that have mandatory holds, to try to get them back facing into the community and get services to them, the access to services as quickly as possible. The second goal is to individualize care and to make sure that the plans we develop have 3 or less components to them that can be accomplished within a short period of time. We've defined that short period of time to be 60 days, that we follow up and look for progress from the individuals we work with. We focus both on first-time offenders and also folks with chronic patterns of mental illness and chronic issues with chemical use. And so those are both within our primary catchment. I'm going to end my testimony by just saying 2 fiscal findings that we've had with our project over the past 2 years as we've been doing this on a full 24/7 basis. First of all, we have a lot of colleges in the Mankato area in Blue Earth County. We've seen $100,000 savings year over year for the last 2 years in detox. And so we have seen an ability to measure success in practice efficiency. And then also with state hospital costs, we've seen a reduction of $200,000 each year for the past 2 years in that as well. So we're proud of that. Our treatment costs are up slightly, which is exactly what we hoped for, that we would improve access to care. And so there's no doubt, though, that there's a clear fiscal benefit overall. We definitely have a black budget in that regard. And so we're just asking for your support to mainstream these services. And what we're interested now, again, as was stated in the open remarks, is for expansion. Thank you for hearing us.
Thank you for your testimony. Please state your name for the record and proceed with your testimony.
Good afternoon, Madam Chair and representatives. My name is Angela Youngerberg. I am the Director of Business Operations for Blue Earth County Human Services, testifying today on behalf of Blue Earth County and MICA, the Minnesota Inter-County Association. Thank you for allowing me to be here today. I am going to walk you briefly through a document that you received. It looks like this. It's a pathways document. And a lot of people ask us about the mechanics of our project. And while I'm not going to go into the mechanics of our project, what I do want to draw your attention to is that we have many ways in which we can engage a person in the Yellow Line project with community-based care coordination, or as the bill states, the officer-involved community-based care coordination. And so anything to the left of the yellow line, you see the vertical yellow line, is representative of the community. And that is where we can actually provide services in a proactive way to reduce unnecessary incarceration. Anything to the right side of the yellow line is something that, based on federal rule, we cannot bill for through medical assistance or any other means. And so what we're trying to do is to push services more into the community for these individuals. This document also goes through the multiple pathways, which we're not going to go through today, but could certainly take questions if there are any. Phil shared with you a bit about the project and some of the fiscal outcomes, but I want to tell you about a few of the other successes and then comment briefly on the details of House File 1254. Last year in our project, we screened 1,615 individuals that came into contact with law enforcement in Blue Earth County. Of those, there was a self-report of 81% of those individuals were struggling with mental illness or chemical dependency needs, which is much higher than what typical reports actually show, because this was done with a plainclothes social worker versus a uniformed officer or jail representative. Of those that were screened, that were then eligible for the program, developed a plan, so went through our entire program, working with the community-based coordinator to link up to community services, over 80% successfully completed their plan. Of those that successfully completed their plan, we're really interested in the long-term impacts, and we've been around for a couple of years, and what our data is showing us is that 6% of those individuals that successfully complete their plan, we see again through screenings. So it's not technically recidivism, but what we're indicating is that by working with their project, we're not seeing them back again through the typical cycle within the jail. There are so many stories that I could share with you, but I think about the overarching ways that the project has positively impacted the lives of people, and I can think of people who are experiencing homelessness, transition age youth, a single parent who resorted to theft so that she could feed and diaper her child, a veteran who was, for lack of a better word, cycling through the law enforcement system every 3 to 4 months. We've not seen him back in our system because we're working with him in the community, or group home residents who were at risk of losing their housing because of a drug charge, and so we were able to work through community services. Earlier this session, we had the privilege of providing an informational testimony in Representative Mariani's Public Safety Committee, and the positive feedback and support that we received from those committee members about our project only further underscores our belief that innovation and integration within social services and public safety is essential to change the cycle that exists for many individuals with mental illness and chemical dependency. In 2016, the legislature supported and ultimately passed a bill that allowed the Department of Human Services to seek a waiver to the state Medicaid plan to allow for community-based care coordination. As we've been working with the department over the years and working with CMS on this waiver, we have a few technical details that need to be cleaned up. That is what this bill does. We worked with the department to address the concerns, and although there was support in both the House and the Senate last year, it was ultimately part of the larger veto. So we're back in front of you today asking for your support again. The bill does 3 things. It expands the credentials for service providers. It allows tribes to be engaged in this service delivery system, and it aligns the non-federal share to the state, which will cleanly address the concerns that were expressed by CMS. Thank you for your time today, and to Representative Considine for authoring this bill. Sincerely appreciate your support for this bill. Thank you.
Thank you for your testimony. Is there anyone else in the audience who would like to testify on House File 1254? Members, we do have a quorum now, so we'll proceed with discussion. Representative Edelson.
Thank you, Madam Chair. Thank you, Representative Considine, for bringing this bill. I'm on public safety with you. This is a really great bill. But I do have questions in terms of when you say The reduction of recidivism, do you have a percentage of, do you have any data that goes with that?
In terms of the recidivism, what our data supports is those that actually completed their plan and worked through our project with our community-based care coordinator. We're seeing, only 6% of those individuals back. Now, what we don't know is if those individuals showed up in other jurisdictions because we don't have the ability to have some of that cross-sectional data. And so we're working to try and get that. We don't have that at this point. But we do know, and we can look back, that some of those individuals we were seeing every couple months come through the law enforcement system, and we're effectively breaking that cycle. Some of them are first-time offenders, and then we never see them again. And it's really hard to talk about what prevention is in those cases because we don't know, would we see them back? And so we are continuing to try and get further into data around recidivism, although the data that we have is not truly recidivism for lack of access.
Representative Edelson.
Thank you. Well, I mean, this program is so important in terms of going and getting to the bottom line of really digging in on why people are possibly committing, some of these crimes. And there are a lot of underlying factors that are there. In terms of looking at the top 3 diagnoses, what would you say that you've seen when you're doing the screenings?
Mr. Clausen.
Madam Chair and Representative, thank you. I am a psychologist by training, so that is in my wheelhouse. I would say depression always is at the top of that list. And, we have that great debate in co-occurring disorders if it's people are medicating their mental health issue or do they have a mental health issue that causes them to use. We see a lot of co-occurring disorders, which are obviously diagnosable as well on the chemical dependency spectrum. And then anxiety disorders for sure are probably at the top of that list.
Representative Edelson.
Thank you. That's all I have. Thank you so much.
Further discussion from members? There being no further discussion, the chair renews her motion that House File 1254 be recommended for re-referral to the committee. Representative Albright, did you have a question? I apologize.
Thank you, Madam Chair.
Profusely.
Representative Considine, you and I probably don't agree on very much, but we do agree on this bill. It's a good bill. Thank you for bringing it forward.
And I would dispute that. I think there's a lot of things you and I agree on. Not a lot of them here in the House, but
You and I and Representative Lunan will get together and talk about it.
yeah, we will.
There being no further discussion, the chair renews her motion that House File 1254 be recommended for re-referral to the Committee on Ways and Means. All in favor say aye. Aye. Opposed? The motion prevails. House File 1254 is recommended for re-referral to Committee on Ways and Means.
Thank you.
I'd like to entertain a motion to approve the minutes from the March 15th, 2019 meeting. Thank you, Representative Mann. Representative Mann moves to approve the minutes from March 15th. All in favor, say aye.
Aye.
Opposed? Minutes are approved. Next, we have Representative Urdahl, who I understand has an out-of-town testifier, and from there, we will follow the order. House File 478.
Point of technicality.
Representative Bonner.
Someone else to approve the minutes from the 15th.
Sorry.
Representative Mann was not here.
Ooh. Good catch, Representative Bonner. Move to reconsider. Do I have a movement? That
Or I will move the minutes.
Representative Bonner moves to reconsider the minutes for March 15th. All in favor, say aye.
Aye.
Opposed? Thank you, Representative Bonner. The Representative Bonner moves to approve the minutes, and they are approved from March 15th. All in favor?
Aye.
Thank you. Opposed?
No.
Division.
Okay. The minutes are approved for March 15th, 2019. The chair moves that House File 478 be recommended for referral to the Committee on Ways and Means. We have the bill before the committee. Representative Urdahl, welcome to the committee. Please present your bill.
Thank you, Madam Chairman and Madam Chair. And pleased to be here today. I believe in my 17 years in the House, this is the first time that I've been honored to be before an HHS committee with a bill.
Very nice.
Treats.
Hello?
HF 478 deals with a very serious issue that is coming before us, the post-traumatic stress disorder, dealing with firefighters. And this bill is asking for $400,000 to create a grant program that gives $150,000 for grants targeting the training of service dogs. $100,000 is for grants targeting education and support for spouses and families, and $150,000 for grants targeting the delivery of mental health services, including treatment and appropriate referrals. I was recently notified of concerns that State Auditor Julie Blaha has regarding this issue. She recently put out a report on the 2017 Financial Investment Report of the Volunteer Fire Relief Associations. And in that report, she says, while we are happy with the health of the funds, we are concerned with the health of the firefighters. We will continue to monitor the magnitude of survival and disability benefit payouts and their financial impacts on these pension funds. The amount paid in survivor and disability benefits increased by 101.1% between 2016 and 2017. So this is a serious problem that is dramatically getting worse. And I have with me today Matt Doty of the Dassel Fire Department.
Thank you. Please state your name for the record officially and proceed with your testimony.
Madam Chair, my name is Matt Dowdy, President of Firefighters with PTSD, which is the organization that is requesting the funds. Essentially what we do is we broke our organization down into 3 different segments, 3 different pieces. We were formed by a group of firefighters dealing with PTSD, so that's where the name came about. We are actually an organization that serves veterans and all first responders, and I mean from corrections officers to ER nurses to you name it. We, if they come to us and want a service dog, which is really hard to do, we try our best to work with them. Now, we have created several tracks on our dogs, and we have several professional trainers as our partners who help us with this, but for veterans, they like to get their dogs a lot sooner because as a part of their therapy, they work with the dogs. If you've heard of Eagle's Healing Nest, Off-Leash Twin Cities Canine Training works directly with them and is partnered directly with us. So we're very closely tied with them. We do a lot for the veterans. When it comes to first responders, we do the same thing. The service dogs is a huge piece to what we do. But the more important piece that we wanted to focus on is we want to provide training for free and put the resources in front of family members that have first responders and veterans that are in our line of work. Because I feel like our families, our board rather, feels like our families are going to see the signs a lot sooner than we're willing to even admit that we may have a problem. So we're going to curb that suicide rate. The other part of the education and prevention is also helping with, I can't afford it, or it's getting expensive, and my wife told me if you didn't have to pay for that copay, we could have taken a family vacation. We're trying to remove the issues that are causing people not to get help. In the first 2 years, I myself and some others have privately funded the work we've done. We've placed 1 service dog, and we are on track to place our 2nd this July at an event. And everything we do, we try to keep right here in Minnesota.
Thank you so much for your testimony. Is there anyone else in the audience who would like to testify on House File 478? Is there discussion from the committee? Representative Albright.
Thank you, Madam Chair. And to the testifier or to Representative Urdahl, I know that work comp went through a very extensive review of PTSD for emergency service personnel and adopted language into the last work comp bill in the last biennium to support the work of recovery and healing. I'm just wondering, this is not to supplant that work, it's a complement to it. And I'm just wondering if you could speak to how the work comp arrangement has been assistive to those folks, and where does the baton handoff occur in some of these circumstances?
Mr. Dowdy or Representative Urdahl?
Mr. Doty.
Representative, I think right now where we're at with that is that bill was passed last year, and I believe it's in language writing. Now, I'm not up here in too much of the know, but I believe that's the last I heard. I do have firsthand experience of guys who we have submitted a claim due to this and have sent to treatment, and it was denied in 2 days. So we're still seeing the denials, and I'm sure that's because they have to, decipher how far do we go back, what will we cover, how is it covered. And as far as us as an organization, we try to allocate a certain a percentage of the person's bills. If they say, hey, I need treatment, it's going to cost $5,000. We try to get them a percentage of it, but then we also network with other nonprofits to see if we can't help get most of it covered. That way, when they're done fighting work comp, whatever's left, we try to just lessen that burden for the immediate sense.
Representative
Madam
Albright.
Chair, and thank you for that information. I'll pass that along at our next commission meeting for work comp. So thank you for that information.
Representative Liebling.
Thank you, Madam Chair. And Representative Urdahl, welcome to Health and Human Services. I'm glad you finally made it. It's great to have you here. So, Representative Urdahl, and to the testifier, I think the problem is extremely serious, and we've learned some about, especially about firefighters. We've heard bills about higher rates of cancer and all of the things that firefighters have to deal with. And, certainly we would like to be able to help address that. But I have some kind of questions just about how this would work, if you don't mind. First of all, I'm not that familiar with the whole thing about service dogs. And does a service dog, is there a prescription for a service dog from a mental health provider? Or does a person just decide, I'd like a service dog, I think it would help me? Or just how does a person get to that point of getting a service dog?
Sure.
Mr. Dowdy.
Representative, I think how I'll answer that question is simply we work directly with the person that's asking for the dog, our team does, and then they also request a verification from their doctor or provider. So we do recommend that as a part of this process, because obviously we opened our application process up for 2 months out of the year. We had 211 applicants. We've been here for 2 years. So in 2 months, we had 211 people with doctor's notes saying, can you help me? I think also a part of that is with psychologists. Some of the dogs are not all the way to a service dog level. They're either ESA, which is emotional support, or therapy, which brings them a different level of comfort. The service dog level is for someone who, with PTSD in this sense, may need help reminders to take their medication, and the dog on their vest has spots for the medication with them. There's many different tasks that they can be tasked with. One of the big ones that we're seeing is nightmares, and being in big crowds. People get anxiety with PTSD, and they feel like they need to be near an exit. So the dogs bring comfort and healing in many different ways, and most often it comes with the long-term working with the dog, developing that relationship. And
Okay.
Chair Liebling?
Thank you, Madam Chair, and thank you for that answer. So now I realize I know even less than I thought I knew. And so is there a definition in statute of what a service dog is? So when the bill uses the term service dog, from your answer, I'm understanding that has a specific meaning, and there must be a definition in statute somewhere of what that meaning is?
Mr. Dowdy, or should we call on House Research?
You can call in-house research, but I'm sure there is because we can't just put out any dogs. They test out, they go through many
Okay.
certifications. So it's,
Chair Liebling.
Thank you, Madam Chair, and thank you for that. And so, and then my other question would be, is there, and I don't know if you don't know the answer, that's fine, but, we're trying to, of course, we're going to have limited resources to do things, especially new projects, and we want to be able to use our money where we have evidence that something will really have an impact. And I'm just wondering if if there are studies that show how well the service dog works. Is there any research on that we can look to say that this approach is better than another approach or anything like that?
Mr. Dowdy.
Madam and Representative, yes, there is tons of research out there that you can find. At our last Senate hearing, we had our professional trainer, Becca, was with us, and she did talk briefly about that. There are a lot of statistics that show they help folks deal with and live with PTSD post-treatment. So now they've gone through treatment and maybe they're on a medication, and what does life look like? Adding that dog in at that point when they're stable and they know what they're dealing with has helped leaps and bounds. Some even return to work.
Okay, thank you, Madam Chair.
Representative Fisher.
Thank you, Madam Chair. To Representative Urdahl and our testifier, thank you for bringing the bill forward, and to the testifier, thank you for your service. I appreciate this being done. I've followed our local firefighters, our local fire department. My son is on the paid on call. He's also full-time on another fire department. So this is an area that I've been paying more attention to over the last couple of years, and I've heard a lot of the problems out there with PSTD and everything else, and I appreciate the fact that there's more being done in this area, and I'm very supportive of the work that you're going to be doing on the bill here, and want to make sure that we get as much of this out in the community as possible. It's a serious effort. You never know when it's going to present itself, and when it does, the quicker we can get treatment out there, the better chance we have of recovery. So I want to support your efforts and encourage you to keep up the good work.
Representative Edelson.
Actually, I was just going to speak
Pass.
to that was, but you know what? Actually, while I have it, thank you, Chair. Just to piggyback off what you were
Never give up
saying,
the
there are
there.
there are qualifying conditions in terms of service dogs, and there is very special training. And as somebody that has worked with kids that have autism and things, they are. We have passed statutory language that the dogs have to go through a certain training to actually be qualified. And so I'm very honored to be a co-author of this bill, Representative Urdahl, and thank you for bringing it.
Further discussion from the committee. There being no further discussion, the chair renews her motion that House File 478 be recommended for re-referral to the Committee on Ways and Means. All in favor, say aye.
Aye.
Opposed? The motion prevails. House File 478 is recommended for re-referral to the Committee on Ways and Means.
Thank you very much.
Congratulations. Okay, we're going to head back to the top of the order. Thank you for your patience, Representative Cantrell. House File 1269. The chair moves that House File 1269 be recommended for re-referral to the Committee on Commerce. We have the bill before the committee. Representative Cantrell, welcome back to the committee. I understand you have an author's amendment. The chair will entertain a motion for the A1 author's amendment.
So moved.
Thank you, Representative Freiberg. Representative Freiberg moves the A1 author's amendment. All in favor, say aye. Aye. Opposed? The motion prevails and the amendment is adopted. Representative Cantrell, please present your bill.
Thank you, Madam Chair and members of the committee. It's a pleasure to join you again. It's an honor today to present House File 1269. This bill seeks to address some of the areas in the delivery of mental health care that we're experiencing the greatest difficulty in, and that, of course, is making sure that we have a full pipeline of people who are preparing to enter the mental health field and who are in the mental health field. Workforce development, I think, is absolutely key to making sure that we address a lot of the accessibility issues that we are facing in the state of Minnesota in terms of accessibility to quality mental health resources across our state. And it's important, or while it's important to focus on increasing the number of mental health professionals practicing in Minnesota, there are other crucial roles to play in providing mental health care as well. For example, in the Native American community, mental health and substance use disorder treatment is found to be most effective when combined with traditional healing services, which is incorporated in this bill. Currently, we can't bill for these services, but they have a powerful impact within the community in making sure that there's a comprehensive approach to mental health care. I know that for all of us, mental health care is a top issue that we care about greatly, and it affects everyone's community across the state of Minnesota. Within the community that I have the honor of representing, there were many folks who I've spoken with, and I've had many friends who either currently struggle with mental illness or who know someone who struggles with mental illness. Or who has lost their life as a result of mental illness. So I take this issue very seriously, as I know we all do. And with that, Madam Chair, I'll turn the testimony over to my testifier.
Please state your name for the record and proceed with your testimony.
Thank you, Madam Chair. Members, Sue Abderholden, Executive Director of NAMI Minnesota. And thank you, Representative Cantrell, for being the chief author. So as you know, we're kind of in the midst of building our mental health system, but we can't build it if we don't have mental health professionals to actually provide the treatment. Back in 2013, the legislature actually directed MnSCU to convene a summit involving all the stakeholders to increase the number of people working in the mental health field, ensure that they're receiving the appropriate training, and to create a more culturally diverse workforce. And there was a lot of work done. There were hearings and surveys, research, and we held the summit. And the report was delivered to the legislature in 2015. The recommendations, I have to say, are very concrete and very doable. And while some have been carried out, not all of them have. And we do know what works in this arena. So first of all, the loan forgiveness program works. We've seen a number of mental health professionals take advantage of that program, especially in rural Minnesota. Making sure that insurance companies pay for the treatment provided by clinical trainees. Some of the private insurance companies do, some don't. Medicaid does. Adding 2 mental health professionals, licensed marriage and family therapists, and licensed professional clinical counselors to the clinical trainee program will help. Paying or subsidizing providers to provide low-cost or free practicum so people can get licensed will help. And training pediatricians to care for children with mental illnesses will expand our workforce and limit the most complex cases to the few child psychiatrists we have. And finally, we want to be sure that we're addressing the needs of the Native American community, which experiences high rates of suicide. I want to just point out there was actually an article or a segment this morning on NPR talking about how we have lots of providers in one place and none in the other. And I just want to mention the counties that actually do not have any mental health providers: Big Stone and Grant, Lincoln, Fillmore, Wabasha, Benton, and Lackey Parle. And so they don't have anyone. And so we want to make sure people are going to have to travel long distance. So, these are all strategies that help bring mental health professionals into the workforce. And again, if we want to build our mental health system, we need to make sure we have people who can carry out the work. Thank you.
Thank you for your testimony. Will you please state your name for the record and proceed with your testimony?
Yes, thank you, Madam Chairwoman and representatives. My name is Jessica Gornall, and I'm currently the clinical director at the American Indian Family Center. I am here today to really address the need for more of the loan forgiveness programs, as well as the need for traditional and cultural healing grants to address mental health needs that are not being met through the traditional Western mental health treatment modalities. In regards to the forgiveness loan programs, when you go to graduate school for a profession in mental health, you're often saddled with a significant amount of student loan debt. One of the major barriers for paying off that school loan debt is that the financial reimbursement for services that mental health professionals provide is not commensurate with the other helping professionals. Another significant financial barrier is that mental health professionals are required to attain a certain amount of supervised clinical hours, often having to subsume the cost of supervision and other licensing fees required to be licensed to work independently. In addition to those barriers, there is another added financial burden for those mental health professionals that provide services in an underserved community, as these positions often provide a lower financial reimbursement rate than at other locations. The underserved communities are usually Native American and communities of color, which suffer from the highest disparities. Overall, there is a shortage of mental health professionals to provide the services that are needed. In addition, the number of people coming into the mental health field has reduced at an alarming rate. This is coupled with a higher rate of mental health professionals who are aging out and retiring from the field. If this current projection continues at this rate, we run the risk of having an even larger shortage overall, but in particular for those willing to work in underserved areas. Therefore, it is essential that we provide additional loan forgiveness programs to address the need to increase the mental health professionals who will choose to work in these communities and continue to work on reducing health disparities. In regards to the second issue around traditional healing practices, we have also seen that in our Native populations and in other communities of color that our health disparities are not improving at a rate that is on par with the mainstream community. Most of the treatment modalities that are provided are Western models that involve the use of evidence-based programs and practices that have not been normed on communities of color or on Native people. While we do not disagree with the use of evidence-based practices, we feel that our community would benefit more by integrating our traditional teachings, values, and ceremonies that have built-in restorative and healing practices with these Western modalities. Our current mental health treatment model is built on a model of sickness, targeting reduction of non-social or problematic behaviors that are causing distress to an individual. This individualistic approach focuses on the mind but does not address the spiritual and emotional needs of people. Therefore, the benefit you receive is limited. However, in Native communities and in communities of color, there are traditional and cultural practices that are embedded in all of these communities that are restorative, healing, and address the whole individual. These practices are embedded in a strengths-based model that has the inherent belief that all human beings have the resources within themselves to attain healing. Therefore, I'm asking that you continue to support traditional healing practices within the Native community and communities of color as a necessary and restorative practice to reduce disparities, but more importantly, to promote healing. Once we heal as individuals, we can heal our communities and others. Thank you.
Thank you for your testimony. Is there anyone in the audience who would like to testify on House File 1269? Is there discussion from the committee? Chair Liebley.
Thank you, Madam Chair, and thank you very much for your presentation. And I'm very intrigued and interested in the cultural healing practices. I think that's great. And I take your point about the fact that they may not be evidence-based. That just means evidence hasn't been gathered, right? It doesn't mean anything doesn't work.
Yes.
But I do want to know how we would, as we go forward, if we're able to, support more of these practices, how will we evaluate them? Because, we do want to, even though we maybe haven't done it sufficiently or the right way, we do want to be able to evaluate it as we go forward because, in a world of always limited resources, we want to be able to fund things that work. And, and of course, it's not that some things work and some things don't. There's going to be sort of a continuum, right? Some things are going to work better than others. So is there sort of a plan to be able to do that?
Yes, thank you. Thank you, Representative, for that question. I also sit on the American Indian Mental Health Advisory Council to the state, and we've been working on this for a couple of years now. We've been looking at programs in New Zealand, New Mexico, and other areas that have found a way to integrate this within their treatment model with the insurance companies. And usually the evaluation, at least from the perspectives that we've been looking at, have been around the use of talking circles and numbers, as well as stories that have been implemented through an evaluation team. So there are methods and ways in which to do that, but the research would not be necessarily quantitative but qualitative, so more stories, narrative.
Chair Liebling.
Well, Madam Chair, thank you. And, and I know that, cross-culturally, I realize this is, it's perhaps a delicate, difficult thing, but there is that, anecdotes aren't data. It's kind of what it comes down to. Stories, although I don't want to downplay that a bit because I know that certain cultures are, stories really are what matters. But I think, though, that when we're making funding decisions between things that are supported by stories and things that aren't, I'm afraid that the stories will lose because that's not how we evaluate. And I hope that going forward we can figure out ways to maybe figure out ways to appropriately have measurements so that even though it's maybe having to speak a different language to us here than the one that this is, than the context of what's being delivered as service, you know, so that we are able to really, you know, figure out how to prioritize this better, I guess is my way of saying it. But thank you very much.
Dr. Cornell, would you like to speak to that?
Yes, I would say that generally what we have been throwing around when you talk about the narrative, there is a way to evaluate that discuss the reduction of mental health needs along with the introduction of increased cultural identity. Many of the mental health symptoms that are reported within our organization are tied to the lack of cultural identity and the lack of embeddedness and within their native community. A lot of these ceremonies actually really do integrate that and increase or decrease social isolation, which is also another huge issue. By being more involved in the community, they're reporting a reduction in mental health symptoms. So I would state that even within that, we'd be able to show within those within the mental health terminology as it is right now, a reduction in mental health symptoms as a result of participation.
Thank you. There being no further discussion, the chair renews her motion that House File 1269 as amended be recommended for re-referral to the Committee on Commerce. All in favor say aye. 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 Opposed? The motion prevails. House File 1269 as amended is recommended for re-referral to the Committee on Commerce. Representative Cantrell. Next up is House File 1256. The chair moves that House File 1256 be recommended for placement on the general register. We have the bill before the committee. Representative Cantrell, I understand you have an author's amendment. The chair will entertain a motion for the A1 author's amendment. Anyone? Representative Fisher moves the A1 author's amendment. All in favor say aye. Aye. Opposed? The motion prevails and the amendment is adopted. Representative Cantrell, please present your bill.
Well, thank you, Madam Chair, and thank you, members. Pleasure to join you again. Today I'm presenting House File 1256. This bill was introduced in the past biennium, and what we're doing now is we're bringing it back, and we're just making a couple changes. Essentially, what this bill does for home care-based support services is, after consultation with the providers, it extends the sunset date that allows providers to add a 5th bed to adult foster care homes. It mandates a discussion of how technology can play a role in an individual's life, in a person who he serves life. And that conversation has to happen at least once a year. And it also adjusts training requirements. Although I do want to outline that in the manner in which this bill adjusts training requirements, it still not only sets a window for training requirements, but also it requires supervision of new employees, and it also requires a few different levels of experience as well. So I understand that there are some concerns about that, and I'm happy to have a conversation about that. Overall, I want to outline that personally I've worked in home care for the past 7 years, and I do know that across the state we are facing an immense, I think, crisis in terms of the amount of folks that we have as people who are signing up to become a part of the home care workforce to take care of our loved ones who either are living with developmental disabilities or who need these supportive services. So this bill seeks to help out a little bit in the pursuit of making sure that we do have a workforce available to help take care of our loved ones in Minnesota. And with that, Madam Chair, members of the committee, I'll turn the presentation over to my testifier.
Please state your name for the record and proceed with your testimony.
Thank you, Madam Chair and committee members. My name is Sarah Grafstrom. I am the Director of State and Federal Policy at ARM. Thank you for giving me the opportunity to speak to House File 1256, which is ARM's policy bill. As Representative Cantrell stated, all of the provisions in this legislation have been identified by our membership as important provisions to providers to help manage the continuing workforce crisis within home and community-based services. At this point, I'm happy to walk through the bill section by section and then stand for any questions. So starting with Section 1, this section will extend the sunset date that allows providers to add a 5th person to an adult foster care home. The language also extends the date for which a provider must be licensed in order to qualify for the 5th bed license capacity. And while the future of services is toward more independent settings, this provision has been important for providers over the last few years to help manage workforce resources. It's important to note also with this provision that in order to add a 5th person to a home, all individuals that live in the home must agree. Section 2 is technical changes updating language for the developmental disability waiver. Section 3 mandates that on an annual basis, providers have a conversation with individuals and their support team on how technology may play a role in their life. At ARM, we have made significant investments in resources to help providers, individuals and their families, and case managers learn more about the assistive technology options that are available. The use of assistive technology can at times be a great supplement for having an actual staff person supporting an individual. And as technology continues to change, we want to make sure that individuals at a minimum are talking about these options annually. Section 4 includes the language that was just amended into the bill, and just a little background on that language. Back in 2017, we passed language that made orientation training and annual training competency-based. It came to our attention in December that the way that language was stated, it left it up for interpretation that only orientation training could be competency-based. And so this language clarifies that previously passed language, making both orientation and annual training competency-based for staff people. And then finally, Section 5, 6, and 7 make changes to the training requirements for the positive support professional, positive support analyst, and positive support specialist position. This language is important to increase access to this important service by expanding the pool of potential positive support professionals, but still maintain the high quality of standards. And with that, I am happy to answer any questions the committee may have.
Thank you for your testimony. Is there anyone in the audience who wishes to testify in House File 1256? Discussion from the committee. Representative Loeffler.
Well, thank you, Madam Chair. And Representative Cantrell knows I have some concerns about this bill. And I am totally sympathetic to the workforce crisis that faces this industry. I have not heard of the ARM bill being introduced to increase their wages, to increase taxes within the state of Minnesota, to enable that to be implemented, or to provide other routes that we have seen other healthcare workforces with workforce shortages. Loan forgiveness was just covered. Incentive, recruitment and outreach support and programming. Instead, what we have, and this is a consistent tradition, is to reduce the investment in the workforce and to put vulnerable people at risk by eliminating training requirements or delaying the training requirements until they have been on the job 90 days or more, up to 90 days. And to me, unfortunately, we see regularly in the press situations in which vulnerable adults in the care of people mostly get great and wonderful care. And I have to totally say I admire the workforce. I admire the providers who do this work with too little a budget and a lot of challenges. But there are always challenges that, unfortunately, when you're desperate for workers, sometimes you end up with someone who isn't as supervised. Oftentimes they work in settings with a lot of responsibility. And to say that we're going to eliminate training, I think actually is going to make it more difficult to have people regard this as a profession, to regard this as something that you have to know something about, that it's not defined as just babysitting. So the bill does a number of things, but the first thing I want to mention is the amendment made it even worse, because the amendment takes away all requirements for annual training of any of this workforce. And the current requirements is you give more training to people with less than 5 years and more with it. That says you're in a profession. That says that your employer and cares about you and wants you to continue to grow in your skills and your abilities. And maybe you can move up to the next career ladder. Some of these higher level professions which are noted in the bill. There's no career laddering here at all. Instead, there's reduction in training. And the statement was made that this would increase access to a pool of applicants to improve quality. And I don't know how you improve quality if you don't believe in training. That doesn't increase your pool of applicants, to take away the fact that that once you get hired, you're not going to be just put in a situation that you can't control, but you're going to get not only initial training, but ongoing training. So especially if you're dealing with people with behavior problems. The bill itself on 9.24 and 10.25 says for various positions that you train within 90 days. And if, for one position, if you've had an associate degree in social services, it may have been in childcare. It doesn't say that it has to be in working with people with developmental disabilities or behavioral issues. So your associate degree could be something totally unrelated to the population you're serving. But if you have that, then you don't have to be trained till you've been faking your way for 3 months with very vulnerable dependent populations. And for other positions, you have to have a you can be exempted if you have a social service degree. I have a social service degree. I haven't used those skills or training since I got out of college in the 70s. I would hope that you'd want me to go through training on positive supports and person-centered care and all those sorts of things before I start writing the care plan for others, because this would be for the analyst position, which actually writes the care plan for these people. And so I'm really concerned that I want to solve the workforce shortage, making it less of a profession, putting people, vulnerable people, in the care of people who have not been trained, particularly those with behavior outbursts. I mean, we've run into, unfortunately, even in state-operated services within the last 10 years, the MEDO situation in which a state-operated service was found to be violating the rights and restraint policies of the state in law. And so this can happen anywhere, but I think it starts by right away orienting employees. What I was told by someone who was involved in negotiations with this language is that the providers asked for this because they have a lot of employees who don't stay 90 days. And so they don't want to invest the training in them until they've proven their dedication. I hope that that's not the case. So I'm really concerned that for a vulnerable population, we're reducing our expectations of the skills that they bring to the job. And I would be glad to work with the industry to talk about, can some things have to happen right away and other parts of the training happen later? But I think there's some training you need on day one when you're dealing with difficult, vulnerable populations.
Ms. Grostrom, would you like to speak to that?
I would, so that was a lot of really important points. So if I don't hit them all, I apologize. First of all, to the amendment, I want to make it clear that we are not eliminating any training topics that are required on an annual basis. In subdivision 4, which is not on this amendment, but in subdivision 4 of 245D.09, it lists all of the different training requirements that individuals are required to be trained on an annual basis. What this does is, instead of having hourly requirements, it says you need to be proving competency on these various training requirements on an annual basis. So we're just taking out the hourly requirements and making sure that on an annual basis, staff are proving competency on each of those different training topics. We know that everyone learns differently, and for some seasoned staff that have been in the position for 30 years, they may be able to prove competency with training for a few hours. With some, it may take more than the required amount. But making sure that all staff on an annual basis are competent in the training requirements that are listed in 245D. To the point about the behavior analyst and behavior specialist, I think it's important to note that with this position, the behavior analyst must have 4 years of supervised experience working with individuals who exhibit challenging behavior as well as co-occurring mental or neurocognitive disorders. So they have to have experience working with this population, 4 years of supervised experience before they can get this position. And then we are having them get the additional 90 or the additional hours of training within 90 days while being supervised by a positive support professional the entire time. So they do have the previous experience. With the positive support specialist, it's 2 years of experience working with, again,
the challenging behavior or individuals who exhibit a challenging behavior as well as co-occurring mental or neurocognitive disorders. So they are having experience working with that population and then again being supervised while getting that training. And to your comment about staff that don't stay the 90 days, I'm not sure where that came from, but that is not why we are working on making this change. Again, we are just working on trying to get staff in the doors so we can be providing this really important service to individuals. Our alternative is to not be able to provide this service.
Representative Loeffler.
Well, thank you, Madam Chair. And passing a competency, and I'm not sure how standardized that is, or if it's just your supervisor says, yeah, keep working, as opposed to investing in training and continuing to improve the skills of someone, I think is something different. But the other thing that I think is really critical is that this bill is also expanding the populations that would be served under this, where the underlying language is related to brain injury and community access for disability inclusion, otherwise known as CADDI. This expands it to community alternative care and developmental disabilities, which while there are similarities between populations in the waivers, there are definitely differences. And that's another reason for training, because if you have done really good work for 4 years with a population that has a particular issue, that doesn't mean that you're ready to be an analyst writing the care problem plan and the behavior response plan for someone with a totally different mental health or behavioral problem. And so it doesn't relate the skills and experience directly to the population they're going to be serving. And I appreciate the fact that ARM and its members serve wide numbers of populations with very big differences. But this expands it to new populations without a commitment to saying, we're going to treat these people like the professionals there are, even if we can't come up with the rate increases to honor them with the professional salaries that many of them deserve. And so I just really feel like here's a bill. We only hear from the Provider Association. We do not have any advocacy organizations sitting in front of us. We don't have any people who in the community have advocated for these populations. It makes me really concerned that we're just cutting back without adding anything. And I don't know how this improves the workforce shortage by reducing our investment in the people who do the work.
Representative Loeffler, would you be interested in working further with the chief author? We could consider laying over the bill for further work.
Madam Chair, I think that I don't know whether the organization sponsoring this would be willing to. I had thought that was going to happen before this hearing. I did have a chance to talk with the chief author, and he was going to try to raise some issues and see if there could be some modification. I'd be willing to work with people. I also think that it's maybe an issue that needs to get further committee consideration, particularly when the rates are based on a certain expectation of what providers are going to do, and if they're going to do less, then maybe we need to channel any savings that come from this into those wages.
Chair Liebling.
Thank you, Madam Chair. And notwithstanding the fact that this was, I guess this bill or a similar bill was put forward in the last session and apparently went to the General Register, I'm a little bit concerned about that track for the bill. And especially with some of the issues that Representative Loeffler has raised about whether they might have fiscal impact, I would really like the bill to come to go to Ways and Means and come to HHS Finance. And, if there is no fiscal impact, great, we could send it to the floor from that point. But I think it might also give more opportunity for Representative Loeffler, for the author, to continue working on the bill. And we are doing a lot of other work with rates for these services, and I think it would make sense to put these policy changes together with the rate changes and kind of consider them all together.
Chair Liebling, would you like to amend the motion?
I would, Madam Chair. I would move to amend the motion to have the bill be recommended for re-referral to Ways and Means.
Discussion on the motion. All in favor?
Aye.
Opposed?
No.
The motion prevails. Further discussion on the bill? There being no further discussion, the chair renews her motion that House File 1256 as amended be recommended for re-referral to the Committee on Ways and Means. All in favor, say aye. Aye. Opposed? The motion prevails. House File 1256 as amended is recommended for re-referral to the Committee on Ways and Means. Thank
Thank
you,
you.
Representative Cantrell.
Thank you.
Thank you,
for your
Madam Chair and
testimony.
members.
House File 1516, Representative Acomb.
Good afternoon, Madam Chair.
Good afternoon. The chair moves that House File 1516 be recommended for referral to the Committee on Government Operations. We have the bill before the committee. Representative Acomb, welcome back to the committee. I understand you have an author's amendment.
Yes.
The chair will entertain a motion for the A1 author's amendment. Representative Pinto moves the A1 author's amendment. All in favor, say aye. Aye. Opposed? The motion prevails and the amendment is adopted. Representative Acomb, please present your bill.
Thank you, Madam Chair and members. It's nice to be back. And just as a quick recap on the amendment, it was really to just change some language that we had proposed in terms of service plan to service agreement because there was a potential conflict with another bill and we didn't want to have any unintended consequences. So thank you for agreeing to that. But House File 1516 was brought to me by the Minnesota Home Care Association on behalf of a coalition of providers and others with expertise on these issues, including Leading Age Minnesota and Care Providers of Minnesota. As you're aware, Minnesotans with disabilities and older Minnesotans and communities around the state rely on home care services so that they are able to remain living more independently and in less costly settings while getting their care needs met. Over the years, individuals involved with home care licensing have identified areas of the license statute that are unclear, unworkable, or outdated. This caused questions about what was expected for compliance and if the law would be applied consistently now and into the future. This legislation is aimed at addressing these specific areas in need of updating or increased clarity. And I'd like to thank the bipartisan co-authors on this bill. And at this time, I'd like to ask Kevin Goodnow, representative from the Minnesota Home Care Association, to provide some more clarity.
Welcome to the committee. Please state your name for the record and proceed with your testimony.
Thank you, Madam Chair, members of the committee. My name is Kevin Goodnow, and I'm here on behalf of the Minnesota Home Care Association. This bill came about, it's started in a process that started about the end of the summer of 2017, where a number of groups got together, provider groups, including advocacy groups, and also the Department of Health. And what we did was identified parts of the Minnesota home care statutes that were obsolete, outdated, or just plain didn't work. And this is the result of that effort. The bill itself includes, even though it includes now 30 sections with the amendment, it really basically does 10 different things. It clarifies language with regard to medical administration that was unclear with regard to the way the statutes were applied before. It redefines or clarifies the definition of standby assistance. This was an issue that we had found out that many providers actually went to an elevated, a comprehensive license rather than a basic license because they misunderstood what was required under standby assistance. In working with the Department of Health, we think we have a better definition around that. So it'll be more clear for providers as to what level of licensure they need when they go forward. There's a number of provisions related to change of ownership in the bill, and I'm sorry, it's not these issues aren't sequential within the bill. They're smattered throughout the bill. The change of ownership issue is just to add clarity to what happens when there's a change of ownership, how the ownership transfers itself, what isn't a change of ownership, what happens with the employees with regard to the change of ownership and the training required related to that, and also the patients and how they're transferred as well. We have start of service issues to clarify exactly when start of service takes place. The language before was a little bit ambiguous. We have the transition of clients issue, that's in section 10. We eliminated some provisions there with regard to infectious and disease prevention and infection control. They were in a number of different sections in the bill. And we clarified them, modernized them, and put them in one section of the bill so it's easier for providers to find and identify in the statute. We had the issue related to service agreements. We modified the language there. One of the service agreement is, there's a number of issues required that are included in the service agreement when we provide services. One of the areas that was identified as being out of compliance a number of times when providers, when an audit would be done, was an issue with regard to the supervision of the people actually providing the care. And there was supposed to be a statement with regard to that in the service agreement. It was left out of a number of service agreements because people didn't understand what was required. Again, we're not changing the intent of what was intended here. We're just changing the language to make it more clear as to what the requirements are with regard to that, in hopes that we will prevent future problems like that. We have some clarifying language with regard to orientation and supervision in here. And we have two provisions in sections 28 and 29 that tweak the language with regard to the existing home care and assisted living program advisory council. In one of those sections, it basically clarifies that when we talk about home care, we're also talking about assisted living, which is also included in which arguably in assisted living you get home care right now. And the other one is to clarify that as a member, if you're a member receiving service, as part of the advisory council, a patient or somebody receiving services is supposed to be included under this. This clarifies that would also include somebody who's received services within the last 5 years. So you don't need to be currently receiving home care services to be considered that member. And then one section deals with deleting obsolete language. Members, this is, would appreciate your support for this bill. This has been a lot of work. It's well, anyway, I'd appreciate your support for this bill.
Thank you for your testimony. Is there any in the audience who wishes to testify on House File 1516? Discussion from the committee, Representative Edelson.
Thank you, Madam Chair. Thank you, Representative Acomb, for bringing this bill. In terms of, if you could go to page 7, line 7.30, the language that you're adding, the change in ownership survey. Wondering is this currently done? It means a full survey of the new licensee due to a change in ownership. Is this current practice now, or are we adding this?
Mr. Goodenow.
Madam Chair, Representative Edelson, I will, if I'm wrong, I'll defer to the Department of Health on this, but I believe this is being done now, and what the requirement is to make sure that there is a full survey done when the ownership does take place.
If the Department of Health could come down, because I actually do want to know what that survey entails also.
Do we have a
Melissa?
representative?
Okay.
Thank you. Please state your name for the record and proceed.
Hopefully you can hear me. I'm from the Department of Health, just not very healthy. My name's Kathy Griffin. I'm the manager of home care and assisted living programs at the Department of Health. Madam Chair and Representative, yes, this is a current requirement. I believe what the members of the group that got together were trying to do is, because we sometimes have concerns with our resources, they were giving us an additional time to conduct the survey, so we would have up to 6 months in order to do it.
Okay, very good. Thank you. And then, Madam Chair, if I have one more follow-up. If page 11, line 11.8 through 11.30, I just want to clarify, is the criminal convictions, so is there a background check done twice, I'm wondering? Is it a background check for a temporary license and then again upon issuance of the license? I guess I would like clarification on that because it's confusing in reading this.
Ms. Griffin.
I guess it's me. Madam Chair, Representative, no, there's only one. So when you get your temporary license, that's when the background study checks are done. Once you pass your survey, so we know that you're compliant with all of our requirements, license, then you're simply issued your, we call it a real license because it's no longer temporary.
Representative Edelson?
Thank you. I hope your voice gets better.
So do I think.
That was above and beyond the call of duty. Thank you for your testimony. Representative Schultz?
Thank you, Madam Chair. I guess I'm concerned with line 2.4 in the bill where you're changing service plan to service agreement. And I'm worried that this could create some confusion and statutory conflict with the elder care bill that's moving through, House File 90. And I'm just wondering if you or in the department want to comment on how we're going to rectify that problem.
Thank you, Representative Schultz.
Representative Acomb?
I'm sorry. Thank you, Representative Schultz, Madam Chair. There was some conversations about that before the amendment was issued, and so I'm going to let Mr. Goodnow respond to that.
Thank you, Madam Chair, Representative Schultz. In working with Ron Elwood, the amendment, the A1 amendment that was adopted removes that section. And it removes all reference to changing the language from plan to agreement because of exactly the concerns that you stated. The way Mr. Elwood, and he could speak for himself, is referred to it as he's worried that there would be some unintended consequences or interactions between the two bills, and we wanted to make sure that there weren't any of those unintended interactions. We'll deal with it in the elder care bill if we deal with it at all.
Representative Schultz?
Thank you, Madam Chair. So will having a tiered licensure for housing with services, how will that interact with this bill?
Madam Chair, Representative Schultz, so the tiered licensure deals with right now, So right now you have the assisted living facility and you have home care services that are provided in that facility. We also, and sometimes the owners of the facility also are the providers of the services as well. I represent the Minnesota Home Care Association that typically provides the services that are provided in a person's home, or the alternative services if the person doesn't want it to use a provider that's the facility provider. We would be the outside provider coming into there. There is an interaction between licensure because currently the home care services provided in assisted living facilities are licensed under this same statute as those folks that are not connected with assisted living facilities. And so there is, the way the bill has been drafted, the elder care bill, from my understanding and my review of it, is they've really tried to make sure they're segmented and separate, but there is a little bit of crossover. And we just wanted to make sure that to the extent there's crossover, that it's consistent and that we're not doing something in this bill that is inconsistent with what's happening in that bill. So we just are trying to make sure that everything is done properly. And we don't have any questions after it's passed that adds confusion, which we're trying to correct the confusion in this bill. I hope that's less confusing.
Representative Schultz?
Thank you, Madam Chair. So I think I'm going to recommend that this goes to this, maybe after government ops, goes to long-term care or HHS finance, where we can look at this bill with the amendments to House File 90 to make sure that they don't conflict before they go to the floor.
Chair Liebling?
Thank you, Madam Chair. And Mr. Goodnow, sorry if I missed this, but could you just discuss the repealer? I don't know if you already did that. I may have missed it.
Mr. Goodnow?
Madam Chair, Representative Liebling, I went through a lot of things rather quickly. The repealer, there's two sections of the repealer. The first part, 144A.45, is repealing the language with regard to tuberculosis prevention and control. That is being taken out of this portion of the bill and recodified in a different part of the bill, or language similar to that. The temporary, the 144A.481, Madam Chair, that looks, Representative Liebling, that looks like obsolete language that doesn't apply anymore because of the dates on it.
I'm sorry, could you say it again?
Madam Chair, Representative Liebling, that appears to be obsolete language.
Okay.
Further discussion? Representative Loeffler. Actually, Chair Loeffler.
Thank you, Madam Chair. And the situation I wanted to discuss was on Section 10, which is on page 10. It's the terms of to suspend or have a conditional license. And it adds on an authority that a home care provider subject to this subdivision may continue operating during the period of time home care clients are being transferred to other providers. And I don't see any consumer protection language that says,
Chair Loeffler, will you speak into your microphone,
oh,
please?
I'm sorry,
Thank
it's
you.
here, but it's not picking up. The language that concerns me is the top of page 11. And it is that the home care provider subject to this subdivision who is subject to suspension may continue to operate during the period of time that home care clients are being transferred to other providers. And if they're being, suspended because they didn't get their paperwork in, but they, as far as we know, the care is great, I don't have a problem with that. But if they're being suspended because several of their personnel have been had serious substantial complaints of maltreatment or neglect filed against them through the complaint system of the state, which we've heard a lot about. This says they get to continue serving people. And I think we have a provision I know for sure, for nursing homes, that when a license is suspended and it's serious, that the state can actually take over and operate the business or make sure that the care is appropriate. And I'm wondering if this potentially leaves clients at risk if we don't put some language that says if the suspension is not due to care concerns or something like that. I don't have a problem if it's because they're not getting their paperwork in or they're not, it's something that wouldn't affect client care. But I didn't see any qualifying language, and maybe Mr. Goodnow could help us understand that.
Mr. Goodnow.
Madam Chair, Representative Loeffler, I'm going to try, and then I have my phone a friend behind me, but I want to try to spare her voice. What I recall of the discussion around this is that currently we don't have any provision in the law that allows for the transition of the continuing care for those people while the home care provider is making this transfer. So this is actually allowing them, in those situations that you mentioned that were less severe, to actually continue to provide the services. Appreciate your concern about the language about in the severe case, where's the consumer protection. It really rests with, and the ability to monitor this rests with the Department of Health. And that's why we left the language as permissive, that they may allow them to continue to provide services. It doesn't require that they provide the services. So we're open to other language around that. And I'm trying to recall a conversation that took place a year and a half ago. So,
Chair Loeffler.
Well, thank you, Madam Chair. And when the Department of Health returns to health, I would be glad to work with them. I did have a situation in which a home care owner who lived in my district, served outside, had his suspended for paperwork issues. At least that's what he told me. I have no idea. It may have been suspended for other reasons. And was frantic about trying to find places for his employees and other things. But I was really shocked at how little information was given and assistance to the people being served by that agency. And this owner said, everybody's calling me, telling me I have to find someone to take care of them. And it just felt like it was kind of leaving everyone in a lurch, and that patients and their family members were calling him, the suspended license holder, saying, how can I find someone? How can I do this? And it just felt like we don't have a smooth transition. And so it just feels like this is an area maybe we need to just give it a little more thought and make sure that the right protections are there if it is for maltreatment or neglect.
Ms. Griffin, did you want to speak to that?
Yes, thank you. Madam Chair, Representative Loeffler. Okay, I'm going to get a tone here. I hope works. It's very infrequent that the department actually suspends a license. There was recently one in the papers that was up north. I don't know where your district is, but I don't think it was your district. So I'm guessing it probably was not a suspension. When we need to take an enforcement, we typically, unless it's just dire circumstances, which this one up north was, we enter into a negotiation process with the licensed home care provider. It's a legal process called a stipulated agreement where we agree to the terms of the closure. And there's a process outlined in statute, and our department is required to monitor that process. We do it together with the ombudsman and the lead agency, which is the local county, and any managed care organizations that might be involved. And so what this particular line of language does, and we don't have a process like the nursing homes do for receivership, which is part of the problem. So if we do need to terminate that license, we need the home care provider to transfer the care to a provider who's licensed in good standing. We monitor that process, but because we've terminated it, if we don't allow them to continue practicing, we really have no jurisdiction over them. So we can't say, okay, you need to do this, you need to do that. We also don't have a way for the Department of Human Services to make payments to them. So this one line will help us to bring a bunch of problems together so that MDH can provide oversight and DHS can continue to pay them as the care is being monitored and transitioned to a provider in good standing, if that helps.
Chair Loeffler.
Thank you. That does help. I still look forward to learning more.
And I'd be happy to talk to you when I can talk.
Thank you. Chair Liebling.
Thank you, Madam Chair. Just briefly, it just occurs to me that I think the language just needs to be adjusted a little bit because the way it reads, it just says it makes it sound like they have the option to continue. And I think what's intended here is that the agency may allow them to continue operating. So I think that with that adjustment, and we could, certainly that could be done later, we could probably fix the problem.
Representative Keel.
Thank you, Madam Chair and members. I guess understanding this gets more complicated when you're in rural Minnesota, where transfers might be miles or hours away to get somebody moved. And so while it is, at times concerning, this language is needed so that they can help fix either the residency or get that person moved if that's needed to be. And of course, as we're going to learn in long-term care too, the services kind of overlap, and there are different services that deal with different care. So depending on the choices we make for our family members, or we ourselves make those choices, it becomes an issue. So, the importance is to protect that resident, but we also give people choices. And then you have to remember in rural Minnesota, like I said, it could be hours away to find a spot. That doesn't mean there isn't somebody down the road. Just means there just isn't any place close enough that is available. So, but we need to make sure that people are safe also.
Thank you. Further discussion? Okay, there being no further discussion, the chair renews her motion that House File 1516 as amended be recommended for re-referral to the Committee on Government Operations. All in favor, say aye. Aye. Opposed? The motion prevails. House File 1516 as amended is recommended for re-referral to the Committee on Government Operations.
And thank you all for your comments. I
Thank
appreciate
you. Next, we have House File 1221, Representative Sandell. The chair moves that House File 1221 be recommended for placement on the general register. We have the bill before the committee. Representative Sandell, welcome to the committee. Please present your bill.
Well, thank you, Madam Chair and members of the committee. I appreciate the chance to talk with you this afternoon and encourage your support for House File 1221. The bill directs the Commissioner of Human Services to allow a medical assistance waiver to Supportive Living Solutions to transfer capacity for up to 3 housing units with services to Hennepin County. This bill was introduced and passed in the House last year thanks to the leadership of Representative Tice. Before agreeing to carry this bill, I toured the facilities at Supportive Learning Solutions presently operates in South Minneapolis. I spoke at length with its vice president, with its assistant director, with its staff, and with residents in their apartments. I asked the Department of Human Services for their opinion on the bill and the history of this provider. MDH is neutral on the bill, and they indicated that Supportive Living Solutions is a responsible provider. My impression was that the facilities were respectful of the residents and that the care was attentive. And I was convinced that the SLS values the dignity of each resident. Mr. Joe Cuoco is Vice President of Supportive Living Solutions and will describe our request in greater detail. Thank you.
Thank you. Please state your name for the record and proceed with your testimony.
My name is Joseph Cuoco. I'm with Supportive Living Solutions. And so Supportive Living Solutions, our mission is to provide to improve the quality of life in our community by providing housing services to adults with mental illness, disabilities, chemical dependency, as well as homelessness. SLS Supportive Living Solution currently has 4 24-hour customized living locations that provide housing and supportive services on site. This allows individuals enrolled in the Community Access for Disability Inclusion waiver to maintain independence while also being a part of the larger community. 3 of these apartment styles, 3 of these are currently apartment style locations, while one of them, called Whittier Place, is more of a group home style. Think of an old school dormitory where you share rooms with someone and then you have a bathroom at the end of the hallway. And so it's this location, Whittier Place, that I'm here talking about. So Whittier Place, which houses 66 clients in 3 buildings, is still a sought-after option for independent living, even though most of the bedrooms are shared. This model might have been ideal for when Whittier Place first opened, but it's not ideal today as we strive to offer services and settings that afford privacy, true independence, and a person-centered approach. We would like to significantly improve the quality of life of these clients by offering all the options for private living space. So our solve is that we would like to transition Whittier's capacity of 66 beds to up to 3 locations in Hennepin County. In doing this, SLS would be able to provide private living space to our clients, decrease the number of individuals with disabilities living at Whittier Place by dispersing some, if not all, of the 66 beds. It would be their choice. They would not be forced to go. And potentially continue to provide services at Whittier Place, but to a much smaller number of clients, and hopefully living in their own living space. This change would still give the tenants opportunities to receive the same supportive services and share their life experiences with peers, but more importantly, it would afford them the privacy and independence they deserve. Having their own private living space will allow tenants to thrive and flourish, bringing renewed life to their everyday living. Thank you.
Thank you for your testimony. Is there anyone in the audience who wishes to testify on House File 1221? Discussion among the committee. Chair Loeffler.
Well, thank you, Madam Chair. And as most people on this committee know, we are under federal court order under the Olmstead settlement to have and implement an Olmstead plan. And Olmstead is not referring to the county near Rochester. It is a U.S. Supreme Court ruling enforced by the U.S. Justice Department and the federal courts that says we are violating the constitutional rights of people with disability and mental illness in Minnesota by disproportionately having them live in segregated settings rather than in the most integrated and independent living settings possible. And so we've had to submit a variety of plans to the court to reduce the number of people who are living in even group homes of 4 to 6 people to living in apartments whenever possible and of their choice with supportive services instead. And so this proposal to create what I would see as 3 large apartments buildings with 22 people sharing a diagnosis or vulnerability to me, once again, starts us down the road towards creating mini state hospitals. They might be nicer looking living quarters in a dormitory sort of setting, you know, an apartment style. But it's once again, you're only interacting with people with a similar diagnosis, similar needs, and staff, rather than integrated community living, which our law provides for. You know, you could take a floor of an apartment building and for economies of scale, have a number of people living together in an integrated apartment building. The problem we have with the courts is that we do not have enough community living options to give people real choice. And the requirement of the federal court, as I understand, is that people have to have realistic choices. And so all of these 66 people would have to be given the choice to live in their own apartment or in the most independent sitting they could, or they could be given a choice to live in a congregate setting. I don't know if it can go as large as this, but I have some concerns that we have one provider who would like to create, I'm sure, what is a cost-effective model based on their finances rather than on the commitments that we've made to integrate people and move them into the community. I also have a concern given that some of these people might be considered possibly triggering an IMD situation in which it's institution for mental disease where you have more than 16 people living in a setting, since they would all be getting support services even if they had their own apartment. I think that would potentially mean that they wouldn't be eligible for medical assistance under the waiver. We would have to pick it up with state paid funds. I'm not an expert on this. I know a lot. To know how it would be interpreted in these particular situations, but getting this big an exception in law, I think, would be setting a precedent that we may regret later if we're forced to downsize these.
Mr. Cuoco, would you like to speak to that?
Yes, please. Thank you, Madam Chair. Representative. So all of our locations meet the CMS requirements of making sure that they're not in an institutional setting. I was also on the stakeholder group for the Olmsted Committee when they were going through what is and is not permitted. And I can assure you that our locations are permitted under federal laws and that we do not do anything that would infringe upon the state or create violations for the state. Again, so our current location has already the 66 clients. All we're doing is transferring from one location to another. And allowing them to have an apartment-style setting rather than sharing a bedroom. It's not an increase in beds. And in regards to our company, there is not a cost to the state or county. It's the burden of cost is on our company, and it will actually cost us more because we'll have to have more staffing in several places rather than one location. So it's not that we're looking somehow to create more financial savings by doing this. It is truly about the people we serve and affording them the quality of life that they deserve. So with that, I'm open to other questions. Thank you.
Thank you. Further discussion? Chair Leffler.
Just to follow up, and like I said, I don't know all the exceptions that are there, but to me, the key thing and the one thing that is absolutely required is that the individual served have choice. And it seems to me that we should have someone independently going to these 66 individuals and giving them a range of options and letting them choose whether they would want to be moved into a collaborative apartment building or whether they'd rather have a different, more community integrated setting. And then we'd really know how many of these individuals even would choose this if this was the option. But we don't have that data in front of us, and that's usually a normal part of a planning. I asked Hennepin County if they have a position on this. They do not because they're still learning. And so I think a partnership in planning would be helpful.
Mr. Cuoco.
Madam Chair, Representative. So I'm sorry, I lost my train of thought of what one of the questions I was going to answer. Could you repeat the first part of what you're saying, and then I would be able to respond? I apologize.
Well, that the whole system, Madam Chair, is supposed to be based on individual choice, and so that we could have the independent case managers working with MnChoices inquire with these individuals what they would prefer to live in, so you'd actually know what the demand is going into the future. The reality is that the kids that are coming out of our big investment in special ed don't look to want to live in these kind of settings. They've grown up with the same expectations of their peers that they're going to move into apartments and go on to advanced training, and they just have a different life expectation than previous generations, who I suspect are more of the people that are served in this building. But that would be one way to do planning, is to actually, with your customer base, assess how many of them would prefer this model versus a range of other options.
Mr. Cuoco.
Madam Chair, Representative. So all of our clients have to choose to live in our program. It is state law for choice. That's not something that we can force upon them. And as I stated, that this would be a choice for them to move. We have the location. Our goal is whether or not they move, that we're providing hopefully individual rooms if enough people move out, where they won't have to share a room. It's not our intention where we're going to force anybody out. Again, so there is choice of the resident on what they would want to do, whether to move on or stay at the current setting. Some of the residents have been there for 10 years. Some of them have only been there for 6 months. Some of them would want to stay there. That's their home. That's all they've known. And we're certainly not going to take that away from them. But I'm sure that there are people there that would want to have a more independent setting, like an apartment, where they have their own kitchen, their own bathroom. And that is what we're trying to provide for those people.
Thank you. Representative Edelson.
Thank you, Madam Chair. I thank you for bringing this bill. And in terms of Representative Loeffler's question, I can tell you people with mental illness, disabilities, chemical dependency, homeless, they want independence just like anybody else. And I think it's important that we provide them options and stop, we have to treat them like people. And so I appreciate the bill. Thank you so much.
Further discussion from the committee? There being no further discussion, the chair renews her motion that House File 1221 be recommended for placement on the general register. All in favor, say aye. Aye. Opposed?
No.
The motion prevails. House File 1221 is recommended for placement on the general register. Congratulations.
Thank you so much.
Madam Chair, thank you. Thank you, committee.
House File 925, Representative Davids. The chair moves that House File 925 be recommended for placement on the general register. We have the bill before the committee. Representative Davids, welcome to the committee. I understand you have an author's amendment or two. The chair will entertain a motion for the A1 author's amendment.
So moved. Okay, just time out. I don't have the A1 amendment here. I have an A2 amendment. Are they the same thing? Thank you. Same thing. Sorry. That's A2. You can have that back. That's fine.
Thank you, Representative Edelson.
Well, Madam Chair, let's put both amendments on if it's okay with the members, and if it's not right, we'll fix it later.
I think we have to do them one at a time, don't we?
Yes.
Madam Chair, I'd move the A1 amendment.
Thank you. Representative Albright moves the A1 author's amendment. All in favor, say aye. Aye. Opposed? The motion prevails and the amendment is adopted. Representative Davids, there was also an A2 amendment filed. Did you want the committee to move that as well?
Yes, that's for the Minnesota School Board Association, Superintendent Association, and the school nurses. And Madam Chair, if I've learned anything over the years, don't mess with the school nurses.
Madam Chair, I'll move the A2 author's amendment.
Thank you. Representative Pearson moves the A2 author's amendment. All in favor, say aye. Aye. Opposed? The motion prevails and the amendment is adopted. Representative Davids, please present your bill.
Thank you, Madam Chair and members, and thank you, Representative Edelson, for your help here. I was -1 amendment. I apologize for that. House File 925 is amended, adds a definition of authorized individual for EpiPens, if we can call them EpiPens. If people, it allows authorized individuals to obtain EpiPen auto-injectors from pharmacies upon presentation of a certificate of training. And the certificate of training qualifications are already in statute. If you would look at the bill, that's very simply what this bill as amended does, and I'd appreciate your support.
Thank you. Do you have any testifiers, Representative Davids?
I do not.
Okay. Is there anyone in the audience who wishes to testify in House File 925? Is there discussion from the committee? Chair Liebling.
Thank you, Madam Chair. And first of all, is this, did this bill go to civil law or is it going to civil law? I think I heard it's going to the general register.
It's on its way to the general register.
And Madam Chair and members, I just wonder, because it deals with, and I don't know, it's really a question, you know, because it has this part about the Good Samaritan protections, whether that wouldn't be a civil law issue.
We're going to check with staff.
Okay, and in the meantime, Madam Chair, if I could ask Representative Davids a question.
Certainly, Chair Liebling.
So thank you, Madam Chair. And Representative Davids, I am a user of EpiPens, and I carry them all the time. And so, and the reason I have them is because I'm allergic to bee stings, right? So if a bee stings me, we better go for that EpiPen. But the reason I carry it in the winter when there obviously are no bees around is because of the chance that somebody around me might need an EpiPen, right? So under your bill, you've got these authorized individuals who now have to have the training. And then you've got the Good Samaritan protection for them, as I'm understanding this. Please correct me if I'm wrong, but what I'm concerned about is somebody like me or just a citizen who happens to have an EpiPen who hasn't been trained, because I understand it's a pretty safe thing, right? So if I was to, if Representative Loeffler starts to have what appears to be an allergic reaction, and I have the EpiPen, and I use it in what I think is a situation where she needs it to save her life, am I now liable because I'm not covered under your bill, which gives Good Samaritan protection only to a certain category of person who's been trained?
Representative Davis.
Thank you, Madam Chair. And Chair Liebling, maybe we could go to council on that. That's a very important question. Or House research.
Are we busy looking that up? Okay, great. Oh, Mr. Chung, yeah. Who's first? Who got it?
Don't all talk at once.
Okay.
Madam Chair and members,
Okay.
I guess I would say I think it's possible that you would still be covered under the Good Samaritan law because you're a person who's at the scene of an emergency who knows that another person is exposed to or has experienced grave physical harm, and you're giving reasonable assistance. That's the Good Samaritan exception.
Okay, Madam Chair.
Chair Liebling.
Thank you, Madam Chair. So if that's the case, and I would still be covered, Representative Davids, what does the bill then add? Or are you just, are you trying to get more people to be trained? Or I'm not really understanding this, obviously.
Thank you, Madam Chair. And Chair
Representative
Liebling,
Davis.
that's the point, is to allow more people to have training, to carry EpiPens, to do exactly what you'd say if Chair Loeffler had an issue. We'd certainly want to save her life. I would.
Do you have a testifier with you?
I guess I do now.
Please state your name.
Madam Chair, members, Joel Carlson. I represent the Minnesota Association for Justice, and I was going to answer Representative Liebling's question along the same lines that staff did. But as our association has watched this bill, and we do care about the immunity section, which we don't have problems with how it's written, but it probably needs an excursion to the Judiciary Committee. But what they're attempting to do here, and it's not my bill, but what they're attempting to do is to get more people who are trained who can actually have the EpiPen. I need one too. I'm allergic to bee stings, but I need a prescription to get one. This allows people who do not have a prescription to have an EpiPen to get trained and use them. So without it, you're not really supposed to even obtain one. This allows both the training and obtaining them, and that's the whole purpose of the bill. The Good Samaritan protection does apply to you so long as you're not receiving compensation. If you read 604A-01, it's for everybody who's not receiving compensation for doing what they're doing in good faith. That's what this bill gets more people trained and allows them to have the EpiPens on them.
Madam Chair, that's what I was going to say.
Yeah,
Thank you.
right.
Chair Liebling.
Right, well, thank you, thank you. I appreciate that. Thank you for your help, Mr. Carlson, and thank you, Representative Davids. I mean, I do think, as I understand it, having now had an EpiPen or two of them for quite a few years, that it's a pretty safe thing. So it's not, so that, even if, say, I think somebody needs an EpiPen, needs the injection, and in fact it's something else and they don't, chances are I'm not going to injure them by giving them Epi when they don't need it. So I appreciate this. Thank you.
Thank you, Chair Liebling. Representative Schumacher.
Thank you, Madam Chair, and I would just like to make a motion to amend the motion to have this actually be re-referred to the Civil Law Committee, or whatever the title is of that committee this year.
There's a motion, or Representative Schumacher makes a motion to refer the bill to the Judiciary and Civil Law Committee. All in favor?
Aye.
Opposed? The motion prevails, and House File 925 will be, if it's acted upon, will be referred to Judiciary rather than to the General Register. Further discussion? Okay. Dr. Representative Mann.
Thank you, Madam Chair. So, Representative Davids, what does this look like? So, for example, like if I have a child with an allergy, they have a prescription for an EpiPen, and in the event that they can't give it to themselves, I can just grab their pen and give it to them. So, I guess, was there a specific situation that this bill came about? Does that make sense?
Representative David.
Yes, thank you. Thank you for the question. And yes, there was an incident actually over in the state of Wisconsin where, and I believe, and don't hold me to this, but I believe it was in a camp setting where the counselor should have been able to have this but didn't, and the child died. And I can get you more details on that. And so that this apparently would correct that situation.
Okay. Follow up.
Representative Mann.
Thank you, Madam Chair. And then in the event that, say, I want to be trained and carry around an EpiPen, I have to pay for that EpiPen?
Representative Davids.
Thank you, Madam Chair. And to the representative, yes, that you would.
Okay.
Yeah.
Further discussion?
And they're expensive.
True. Okay, there being no further discussion, the chair renews her motion that House File 925 as amended be recommended for re-referral to Judiciary and Civil Law Committee. All in favor say aye.
Aye.
Opposed? The motion prevails. House File 925 as amended is recommended for referral to the Judiciary Committee.
Thank you, Madam Chair and members.
Thank you. Next, we have House File 2252, Representative Koznick. Welcome. The chair moves that House File 2252 be recommended for re-referral to the Committee on Government Operations. We have the bill before the committee. Representative Koznick, welcome to the committee. Please present your bill.
Thank you, Madam Chair, and to the committee. It's a pleasure to be with you today. I was thinking maybe I was going to have to come back later tonight, so appreciate the time. I am here to present House File 2252, which would add taxi cab owners and operators to the Non-Emergency Medical Transportation Advisory Committee. And the bill language was approved at the January 25th Non-Emergency Medical Transportation Advisory Committee meeting. And with us, I have a testifier, Mr. Zach Williams. He's the general manager of Blue and White Taxi, to speak on the bill, if you wouldn't mind.
Great. Please state your name for the record and proceed with your testimony.
Madam Chair and members of the committee, my name is Zach Williams, and I am the general manager of Blue and White Taxi. We do a significant amount of NEMT transportation, over 350,000 rides a year, and we really appreciate this opportunity to have a voice at the table and participate in making this kind of transportation more efficient and convenient. Thank you.
Thank you for your testimony. Is there anyone else in the audience who wishes to testify on House File 2252? Is there discussion from the committee? Chair Liebling.
Thank you, Madam Chair. I guess I'm glad to hear that this was, the advisory committee approved the bill, or is the bill, Representative Koznick, is it coming from the advisory committee essentially?
Representative Koznick.
Madam Chair and Representative Liebling, it's an idea that the taxi cab has not been part of this committee in the past, and they obviously can provide a needed service. And through the advisory committee, they have recommended this bill come forward to add the taxi cab owners or operators onto the committee to help do their work.
Chair Liebling.
Madam Chair, and I don't know if this bill is this going to the floor? GovOps. Oh, GovOps.
Operations.
Okay, well then I won't ask my other question because we'll let GovOps deal with it. So,
Okay.
thank you.
Representative Albright.
Thank you, Madam Chair. And to the question of Representative Liebling, there is Peace and Valley from the NEMT Commission, so we would encourage an affirmative on this legislation. Thank you.
Further discussion? There being none, the chair renews her motion that House File 2252 be recommended for re-referral to the Committee on Government Operations. All in favor say aye. Aye. Opposed? The motion prevails. House File 2252 is recommended for re-referral to the Committee on Government Operations. Congratulations.
Thank you very much.
We will meet tomorrow at 2:30, same room. Good job, Team HHS Policy. We finished early. We are adjourned.